Hello, and welcome to the Clinical Practice Guidelines for Croup. This is a presentation for 750R Nursing Graduate College at UNLV, and this will be presented by Erin Sisilski, Sharon Projoshi, Whitney Smith, Alyssa Sturm, and Winnie Wang. Welcome. So basic objectives and overview that we'd like to accomplish by the end of this lecture is to just review some basic epidemiology and etiology of Croup, and mainly the clinical course and presentation and the most recent practical guidelines to use in your practice. Croup is a very common respiratory illness that you may see in your office. Also widely seen greatly in the emergency department, but we also want to give you some guidelines for the management and also some symptoms to look out for if you do have to send your patient to the emergency department. Okay, so what exactly is Croup? Croup, also known as laryngotracheobronchitis, it's a very big word, probably why we call it Croup. It's a common respiratory illness in children. It's common outpatient and inpatient. Croup is responsible for up to 15% of emergency department visits due to respiratory disease in children in the United States. It also accounts for 15% of the respiratory illnesses seen in children in general. It's a syndrome that includes spasmodic croup, also known as recurrent croup, and laryngotracheitis, which is viral croup. Recurrent croup and viral croup account for most of our cases, so that's mainly what we'll be talking about. We will be talking about some rare cases, just things to look out for in the future slides. So yeah, you might see it in your practice. All right, so with the epidemiology, you're gonna see this more in males than females. It's a 4-to-1 ratio male to female. It mostly occurs in children between 6 and 36 months of age, although cases have been seen up to 6 years of age. It is uncommon to see children older than 6 years have this, but we do see it with adolescents. It can occur. You might see them have more of like a laryngitis type illness without any respiratory symptoms or severe respiratory symptoms. Your mean age you're going to see, and it says on the slide peak occurrence at 2 years. The actual mean age is 18 months. So it is most prevalent in the fall. It peaks in the fall season. October is the most common for parainfluenza viruses, which accounts for a lot of our Croup cases. And if you do ever work in the ER, you might see Croup. It's more frequent between the hours of 10 p.m. and 4 a.m. when parents bring their children in. So you might, if you ever do work in the emergency department, you might see this. Outpatient-wise, this is good to know that it does occur mostly at night, which we'll go over. All right, so 80% of cases of Croup are caused by viruses. The most common virus that is causing Croup is the parainfluenza. It's parainfluenza type 1 and 2. That's about 50 to 75% of patients. So mainly parainfluenza is the culprit. You might see parainfluenza type 3 viruses in young children, but it rarely develops into Croup. So it's usually type 1 and 2. Some other viruses that can occur in young children are enteroviruses, human bocavirus, influenza A and B, which is a good side note for your education later to advocate for the flu vaccine. Respiratory syncytial virus, RSV, rhinovirus, and adenovirus. And the other 20% causes, there are some bacterial causes that are rare, but if you do see this, it can be diphtheria, which most children are vaccinated against, and Mycoplasma pneumoniae. Now, I do want to go over some risk factors that you want to keep in mind for your outpatient practice. Certain children are more at risk and can develop a little bit more of a severe disease with Croup. These kids include Down syndrome, subglottic stenosis, any prior history of Croup, because you're looking for that recurrent Croup, hyperactive airway, which is common in atopic children, so like asthma, And then any pre-existing airway swelling. Croup causes a lot of swelling in the airway, so if you already have somebody with swelling in the airway, such as laryngotracheomalacia, then you might have some more issues with it. All right, so your clinical presentation. So guys, this is a very abrupt onset, usually occurs at night. So your primary symptoms of croup are a barking cough and hoarseness. Inspiratory stridor are highly suggestive based on clinical assessment and according to our guideline of American Academy from Family Physicians, which is mainly where we're getting our guidelines. And mild croup will last a little bit less than 1 week. You're going to see some kids with some low-grade fevers. Most children develop a fever. So if you have a child who doesn't have a fever, you might want to think of other differentials. Inspiratory stridor is very indicative of croup. The symptoms will start gradually. Then they begin with nasal stuffiness and a runny nose, so very basic upper respiratory illness symptoms. And then the difficulty breathing can develop and become worse during the first 12 to 48 hours. So this is very abrupt onset. So when you're gathering your history, that's something to note. So it's after any congestion and barking cough begins. You can see some other symptoms like rash, conjunctivitis, swollen lymph nodes, but they're rare. Stridor, I like to call this stridor at rest or inspiratory stridor, occurs in the upper airway, and then that's when you have the narrowing of the airway. Becomes very high-pitched with noisy breathing. Some kids sound like seals. Some people describe it as a dog barking. And any agitation can increase the narrowing, so it can lead to more difficulty breathing. So it's very important to keep these children very calm. So a little pathophysiology review. As we know, children have smaller airways than adults, but you have your voice box and your larynx, as you can see the first picture above, which is normal. You have your vocal cords and your trachea windpipe. The virus, when it infects the nose and the throat, it then progresses to the larynx and the trachea, and then the larynx and the trachea become swollen, as you can see on the bottom picture, and it makes it very, very difficult for air to enter the lungs. So this is a very important concept to gather, because the virus is not attacking the lungs, but it's affecting the lungs because it's not allowing the inflammation in the airway is not allowing any air flow to the lungs. So differentials. So you always want to consider any differentials for any kids in croup. Just to give you a little insight, a small study of 60 patients with croup presenting to the emergency department in Wales showed that recurrent and non-recurrent croup have similar rates of viral detection. And then some bacterial tracheitis may result from a secondary infection. So that's a very rare illness. But usually these illnesses for bacterial tracheitis, they don't respond to basic treatments of croup. So that can help you rule out a differential for that. These kids are a lot more toxic looking than anybody with croup, so that's another way to kind of rule that differential out. This one is big, the inhalation of the foreign body. Sometimes I like to give a little anecdotal experience. If you have a child who's got the stridor at rest and they can't tell you what's going on, like if they're, say, 18 months or if they're 12 months of age, and we're not quite sure if they didn't have any upper respiratory illness symptoms prior to the stridor, if there is no low-grade fever, consider a foreign body. They might have swallowed a quarter and behind their mom's back. That can cause stridor too, because that's going to cause some inflammation in the airway. Also, the rest on this list, any peritonsillar abscess, very important to do a throat exam, because if there's an abscess there, it's going to constrict the airway even more. Or retropharyngeal abscess, all anatomical. Also consider angioedema, any allergic reaction. That's going to cause stridor also. It can cause drooling, it can cause stridor and difficulty breathing of the airway. So these are all differentials that we should consider. So how do we diagnose croup? How is the diagnosis determined? Well, it's based on clinical assessment. It's the abrupt onset of barking cough, hoarseness, and inspiratory stridor. That's highly suggestive of croup, especially if you have a little bit of a low-grade fever. And this is huge. The absence of wheezing, that's the physical examination. Croup does not affect the lungs or the bronchioles like asthma does. Croup is all airway because the viral infection is attacking the larynx and the windpipe. So that's obstructing the airway. So when you listen to the lungs, they should be clear. And the diagnosis also involves assessing the severity. So this is why we must look at the respiratory status, like if they have any retractions, accessory muscle use, stridor consistently at rest, how severe that is, and as of course our respiratory rate and heart rate. And then another part of the severity status, and we'll go over this in further algorithms on the next slide, is a change in mental status. Usually somebody with mild croup or a child with mild croup is going to look well. They're not going to have any change in mental status. And as it gets more severe, from moderate to severe, you will have more of a change in mental status. All right, so to get the x-ray or to not get the x-ray? Well, we can use it to rule out differential diagnoses, but are we going to want to do this in our office? Maybe, maybe not. Like I said, if you're suspecting a foreign body, you're definitely going to see that on a soft tissue x-ray. And this is big. A chest x-ray cannot diagnose croup. I repeat, chest x-ray does not diagnose croup. A Cochrane review of 2 randomized trials with a total of 2,024 patients found that chest radiography did not change the outcome of ambulatory children with lower respiratory tract infection. Therefore, physicians should consider the risk and expense of radiology versus its possible benefit before ordering the test. You can use a bronchoscopy in recurring croup, so this is important for outpatient. If they are having recurring croup, you're going to want to maybe order this for your patient to rule out any anatomical disorders such as subglottic edema, stenosis, or cysts. So that's something that's big in the primary care setting if you need to do any imaging at all. Otherwise, a lot of these neck radiographs can help diagnose emergent type illnesses such as epiglottitis or a retropharyngeal abscess, which you will not be treating in your office. All right, and then the American Academy of Family Physicians has also given us a nice algorithm. I like this one because it gives you the dose of dexamethasone on here, and it also goes over mild, moderate, and severe croup. As far as our general management, this is very important. If you have a symptomatic child, you need to keep them calm. The previous algorithm that I just showed you for the outpatient croup is based on the severity of the illness, but it is in general, it is important to keep the symptomatic child calm because it might worsen the airway obstruction. So for example, if your child is a little agitated and you can hear that stridor with the agitation, I might not choose to do a blood pressure. I might opt that out. Or whatever makes them comfortable. There are no studies showing that there's any particular position. You just need to keep the child comfortable and do your assessment as fun as possible. You can use bubbles, let them cling to the parents. You can position them whatever comfortable position they would like. So for mild croup, this is the guideline from the American Academy of Family Physicians. So for your assessment, you're not going to hear audible stridor at rest. You may hear some occasional barking cough, starting with a little bit of a respiratory illness with an abrupt onset within the 12 hours of this. They can be successfully treated at home. We are going to give them a single dose of a corticosteroid. You can give this oral, parenteral, or IM. There's not any studies showing that the efficacy is different between oral or IM, but if they're vomiting or if they're upset, you have the option to give it IM so they can absorb the medication. And we'll go over a little bit more of dexamethasone in another slide. You also want to give your parents some education about the croup and when to seek care. So the guidelines for moderate croup, you are going to see a little bit more of respiratory retractions while resting. You can hear the stridor, but it's not so severe where you need oxygen therapy or possible intubation, but you're almost pretty close. So we are going to administer that single dose of the corticosteroid. And for moderate croup, this requires immediate attention. You're going to need to send these guys to the emergency department. They recommend to observe them for up to 4 hours. We're not giving them any breathing treatments at this time, but if the symptoms do not improve, we're going to escalate to that care for the severe croup algorithm. Some treatment may include, and I say may because it's not necessary, but it's based on assessment. You can give them humidified oxygen, IV fluids if they're dehydrated. We're going to monitor them for these 4 hours also. And this is where you get to your severe croup. And again, these kids should be in the emergency department. But if you see them in your office presenting this way, you will want to call 911 or send them right away. They're going to have a frequent barking cough, severe respiratory retractions while resting, audible marked stridor. It's going to probably sound like they swallowed a seal. They have visible distress. They're not as alert. Regardless, we're still going to give a single dose of corticosteroid. If you're going to send them to the emergency room, get that steroid on board. At the emergency department, they're probably going to be giving the nebulized epinephrine. So this is adrenaline, but it reduces the swelling in the airway. It's a rescue medication. It is not albuterol. It is nebulized epinephrine. And it begins to work faster than dexamethasone. And if you have this in your office, it's great. You can use it and then send them on their way to the emergency department. They will still need to be monitored for 4 hours due to the fact that they could have a rebound effect. And then again, like I said, observe them for up to 4 hours because of the rebound effect. Treatment can include, and most likely will include, some IV fluids, admission status, monitoring of oxygen levels, breathing. In the severe cases, you might intubate the kids with mechanical ventilation, and they'll be in the PICU. Some more guidelines that the AAFP recommends for the management of symptoms. I like to go over the humidification therapy. It is commonly prescribed. You do see this a lot, but it is not as beneficial. It has been long used as a treatment for croup, however, has not been shown to reduce croup severity, hospitalization, additional medical care, or epinephrine and corticosteroid use in patients with mild to moderate illness in the emergency department. Even if delivered with a particle size that could reach the larynx, it's still not recommended, and there's no studies saying that it is beneficial. Although if oxygen is administered to reduce the agitation, humidification should be considered to avoid insipidation of secretions. So it's possible this is why it is commonly prescribed. Corticosteroids, basic guideline. Give it for mild, moderate, and severe croup. It's dexamethasone. That one's recommended more so because the half-life is between 36 to 50 hours. And it's a standard dose of 0.6 milligrams per kilogram to a maximum of 10 milligrams. So that's very important. If you have a bigger kid, and it exceeds the 10 milligrams, you just cap it off at 10 milligrams. And then there's, of course, the epinephrine. A small number of randomized trials have shown that nebulized epinephrine is an effective treatment for moderate to severe croup, with benefits such as reduction in croup severity, various objective pathophysiology measures, and need for intubation. So backtracking to the moderate algorithm, it doesn't say that you should give epinephrine, but the studies say that it does help. So these are guidelines. If you're going to be watching a child for 4 hours anyways, they may benefit from some epinephrine to reduce the inflammation of the airway. And there's another slide of the humidification like I was talking about. The corticosteroids are beneficial even in mild illness. Humidifications doesn't really improve, but unless you are using oxygen. And then the nebulized epinephrine improves outcomes for those with moderate to severe croup. Just a little review. And there's another slide on the evidence-based support for humidification. Everything I just said, just in writing. There was a little study of an outcome of 3 studies for the emergency department on 135 patients. With mild to moderate, it did not show a great improvement. But that was a study in 2007. And like I said, corticosteroids from mild to moderate to severe. Single dose of dexamethasone should be given to all children with croup, as it decreases the need for additional care for 7 to 10 days after the initial visit compared to placebo. And you can give it oral, inhaled, and intramuscular. They're the first line of treatment for viral croup, regardless of severity. Dexamethasone IM and oral have comparable efficacy. Just like I said earlier, doesn't really matter. It's to your comfort. If you feel like the child's going to vomit the single dose, IM injection is another option. A little bit more evidence-based support. And there's the Cochrane review. Looked at 8 studies. 6 of the 8 had low bias risk. Improved croup symptoms in children at 30 minutes following the treatment, but effects disappeared 2 hours after the treatment. And this is the website where you can find the AAFP clinical practice guidelines. It's the American Academy of Family Physicians, and there's the link. Questions and answers. These are some questions and answers that I thought might kind of stimulate some thinking for the clinical practice. Just something like we talked about. Is humidification currently recommended? Not shown to be helpful for croup with mild to moderate croup, but it has not been shown to reduce severity, course of hospitalization, additional medical treatment, or impact the need for epinephrine and corticosteroids in patients. Should all children with croup receive steroids? Answer: yes, you should. Regardless of the severity, steroids are now the #1 line of treatment for croup. We have meta-analysis supporting the use of dexamethasone and sometimes budesonide, showing that a steroid result in significantly clinical improvements in the first 24 hours after treatment. And how can croup be prevented? You have a parent coming into the office afraid of their child getting croup. Unfortunately, there's no vaccine available for croup, but you can receive an annual influenza vaccine, as influenza A and B can cause croup also. Of course, avoid close contact with those that are ill, and hand hygiene, nursing 101. Other treatments, something that your parent might ask. Can antibiotics help it? Well, we know antibiotics do not treat viruses, which cause most cases of croup. And if there is a bacteria that is causing the croup, they should be hospitalized with IV antibiotics. So there is no antibiotics that, there is no script that you can write for your patients to heal croup. Other therapies such as cough medicines, over-the-counter, decongestants, and sedatives, not routinely recommended for children with croup. And then sedatives, this is very important because you want to keep the child calm. They can mask the symptoms of low blood oxygen and difficulty breathing, so those are not recommended. If somebody has ever heard of Heliox, helium and oxygen mixture, it can be used to decrease airflow resistance, but studies have shown insufficient evidence for it being beneficial in patients with croup. Okay, so these are our references. And that concludes our presentation for the clinical practice guidelines of croup. We hope that you've enjoyed this presentation on behalf of Group 2 for 750R. And you guys have a great weekend and a great week, and happy studying. Thank you.